Hello everyone, my name is Dr. Sikandar and today we will discuss about the importance of chest X-ray in pleural disorders and importance of CT. So first we will discuss about the importance of chest X-ray in pleural effusion. So yeah, there is a meniscus sign which is seen in pleural effusion. Here you can see this is the meniscus shape and this is the this opacity is due to accumulation of fluid, and they are telling like it needs 175 ml pleural fluid to obliterate the costophrenic angle. So yeah, this is the costophrenic angle we can see in left side, but in right side it is obliterated, and this is like meniscus sign is visible, and this is the left sided pleural effusion which is obliterating left costophrenic angle, and it requires 175 ml which can obliterate the costophrenic angle in PA view in chest x-ray. So they are telling like why costophrenic angle used to blunt first, and like why opacity is like that, how why it used to proceed like this. So yeah, they are telling like the distance between the lung and chest wall is the same around the entire lung. Like they are telling this is the lung, this is the chest wall, so this distance is equal like along the whole lung, entire lung. The depth of the fluid when viewed on PA view, like A to CC, like from here they are telling like from here to here, this distance is like is not sufficient to increase the radio density, but like from D to F in this area, like here X-ray beam has to pass from more fluid, from like continuously from the fluid, so this area is more dense. That's why this is visible in the chest X-ray. So there is an entity which is known as subpulmonic or infrapulmonary pleural effusion. So pleural fluid more than 1 liter can be present and may remain in an infrapulmonary location without spilling into the costophrenic sulcus or extending up to the chest wall. So it will not go into costophrenic sulcus. So it will not obliterate the costophrenic angle, but it will be there in the infrapulmonary location, and the amount will be more than 1 liter. So then how we will define it, like how we will diagnose it. So they are telling there will be apparent elevation of one or both diaphragm. So wherever effusion is there, there will be like elevation of diaphragm on that side. Then they are telling in PA view chest X-ray, the apex of apparent diaphragm is more lateral than the usual, near the junction of middle third and lateral third of the diaphragm, rather than at the center of the diaphragm. So yeah, this apex here we can see this is the apex, which is like more laterally, like at the junction of 2/3 and 1/3 of this diaphragm. And normally it used to be in the center. Like normally it used to be here, but in this case it is here. So yeah, we can see like apex of diaphragm is more lateral in subpulmonic effusion. After that, they are telling like the apparent diaphragm slopes more sharply toward the lateral costophrenic angle, like this. Like this will be like more sharp decline. Then they are telling that if the subpulmonic effusion on the left side, the lower border of lung is separated further from the gastric air bubble than usual. Normally, the top of left lung on the posterior anterior view is less than 2 centimeter above the stomach air bubble, but in separation greater than more than like 2 centimeters suggests a subpulmonic effusion. But of course, it can be due to subdiaphragmatic fluid accumulation. And they are telling if no gastric air bubble is present, then we can give the patient the carbonated beverage, and then we can evaluate this sign. So yeah, here we can see this is the left-sided pleural effusion. Like this distance between the gastric air bubble and the diaphragm is more than 2 centimeter. So in this case here we can diagnose like this is the left-sided pleural effusion. Yeah, but in some cases it could be infradiaphragmatic effusion also. So yeah, after that they are telling in lateral projection the major fissure often goes anteriorly, where it meets the apex. They are telling like where it meets the convex upper margin of the fluid. A small amount of fluid is usually apparent in the lower end of the major fissure at its junction with the infrapulmonary effusion, and the lower lobe vessels may not be seen below the apparent diaphragmatic border. So they are telling like if there will be subpulmonic effusion, then the vessels in the inferior lobe will not be visible. So yeah, these are like 5 6 signs. Then we can see in this diaphragm like this is the subpulmonic effusion in the right side, and this is the subpulmonic effusion in the left side. Here we can see like there is elevation of the diaphragm, then like effects will shift to more laterally, and this will be like this angle will be like more decline, And here we can see on left side, like there is more than 2 centimeter distance from the gastric wall to left diaphragm. Yeah, now they are talking about the AP view of the pleural effusion. So let's start about the AP view. So they are telling like earliest sign is blunting of the costophrenic angle. Obviously, costophrenic angle blunting is seen in PA view also and like AP view also. And in AP view, it is the earliest sign. Subsequently, increased density of the hemithorax, loss of the hemidiaphragm, and decreased visibility of lower lobe vasculature occurs. Apical capping does occur with the pleural effusion, but it does not appear to be related with the size of the pleural effusion. So yeah, apical capping will not define the size of pleural effusion. Elevation of hemidiaphragm and attenuation of the minor fissure are insensitive sign in that they occur in a minority of patients and are not related to the size of effusion. Yeah, very important. After that, they are telling like there are 3 characteristics which serve to differentiate the increased density due to pleural fluid or from the any parenchymal infiltrate. So yeah, how to differentiate between like parenchymal infiltrate or pleural effusion opacity in AP chest X-ray. So yeah, first sign is like if the density is due to pleural effusion, the vascular structures of the lung will be radially visible through the density in a properly exposed film. Means like it will be like blood vessels will be visible through this density. Any intrapulmonary process like any parenchymal involvement that produce a similar density, however, obliterate the vascular structures by the Silhouette effect. So like by Silhouette effect, these vascular structures will be obliterated. And secondly, they are telling if density is due to pleural fluid, it is usually completely homogeneous. In contrast, infiltrate caused by intrapulmonary process are usually less homogeneous. So yeah, this is also very important. So they are telling like it will be completely homogeneous due to pleural effusion opacity. Third is like ear bronchogram are present only if increased density is due to parenchymal. So in parenchymal infiltrate, there will be ear bronchogram sign will be present. Very important. After that, here we can see this is the AP view chest X-ray and like it is showing the right-sided pleural effusion. So yeah, patient will lie down and like this whole fluid will be like distributed throughout the right lung and like it will be visible like a density, homogeneous density. So where here we can see like this is the homogeneous density and through this density we can see the vessels, vascular structures are like very easily visible. So yeah, after that and this is like homogeneous density and like bronchogram sign is not present in this condition. So yeah, all 3 criteria are meeting. After that, they are talking about the atypical pleural effusion. So yeah, we used to discuss like pleural fluid used to accumulate in the costophrenic recess, but here in this case, it is not accumulating here and it is accumulating more on the medial side. An atypical collection of the pleural fluid is an indication of underlying parenchymal as well as pleural disease. For example, if disease in the lower lobe increases its elastic recoil, fluid will collected more in posterior medial direction. Accordingly, in the PA view, the opacity is higher on the mediastinal than the axillary border, in contrast to the typical appearance in which opacity is higher on the axillary border. So here we can see this is on the mediastinal side. So yeah, uh, it is also denoting like disease. There is a disease in lower lobe. Because of that, there is in like increase in its elastic recoil and it is not compressing the left lower lobe. Oh, sorry, right lower lobe. Then they are talking about the loculated pleural effusion. Pleural fluid becomes encapsulated by adhesions anywhere between the parietal and visceral pleura or in the interlobar fissure. We should not forget this. It can accumulate also in the interlobar fissures. Because the encapsulation is caused by the adhesions between the contiguous pleural surfaces, it occurs most frequently in association with condition that causes intense pleural inflammation. Means if there is presence of loculated pleural effusion is there, then it suggests that it is due to intense pleural inflammation such as empyema, hemothorax, or tubercular pleuritis. So loculations are if loculated pleural effusion there, then it is due to chronic disease, any chronic disease like either empyema, hemothorax, or tuberculosis pleuritis. Then they are talking like loculations occurring between lung and chest wall produces a characteristic radiographic picture. When viewed in profile, the loculation is D-shape. So it is usually D-shape with the base of D is against the chest wall and the smooth convexity protruding inward toward the lung because of the compressibility of the lung parenchyma. So it is like D shape, and this D ka base is there on the chest wall, and this like uh, convexity is toward the lung surface. If the loculation is in the lower part of the thoracic cavity, the lower border may not be visible, and loculation may be differentiated from the parenchymal infiltrate by the absence of air bronchograms. So, like absence of air bronchogram can easily differentiate it from the consolidation of parenchymal infiltrate. A definitive diagnosis of loculated pleural effusion is done by ultrasonography, USG. So, yeah, by USG we can easily differentiate the loculated pleural effusion from any like underlying disorder. So here we can see this, these are different kind of diagrams are there. So here we can see like left-sided loculated pleural effusion there. Here this is like D-shaped pleural effusion, and this is like D-shaped pleural effusion on the right side. Here we can see this is also, and like these all three are like same picture from like the same patient. And here we can see like in right lateral decubitus position, like this fluid is not like going distributed it used to happen in normal pleural effusion. It is here, it is loculated only. And in CT, we can see this loculated effusion is there. Yeah. So what is like phantom or vanishing or pseudo tumors? What is phantom tumor? What is vanishing tumor? What is pseudo tumor? So they are telling if fluid encapsulated in a fissure look like biconvex lens, its margin are sharply defined by a sharply defined and blend perceptively into the interlobar fissure. So inside the interlobar fissure, there is accumulation of fluid, and it used to give appearance of biconvex lens, and margins are very sharp. Here we can see this is, he is talking about the here in this picture we can see this is biconvex shape accumulation of fluid in the interlobar fissure. In some situations, the loculated effusion may simulate a mass on the PA view. So it used to confuse us with the mass. Like we used to thought like it could be because of mass. This situation is most frequently seen in the patient with congestive heart failure. Very, very important. So it used to be occur with the patient with CHF. And because the fluid absorbs spontaneously when the congestive heart failure is treated, when we used to give the patient furosemide, these accumulation of fluid used to be resolved spontaneously. So they are telling like these fluid collections have been termed vanishing tumors or pseudo tumors. Very, very important. So we used to tell them that these are pseudo tumor or vanishing tumors. The most common location of these tumors is the right horizontal fissure. So they used to be occur in the right horizontal fissure. So this is the most common location of phantom tumors or vanishing tumors or pseudo tumors. And they are telling like these are usually less than 4 centimeter. Like their size is in most of the cases is less than 4 centimeter, but pseudo tumors as large as 10 centimeter in their largest diameter has been also reported. So they are telling like they has been reported like more than 10 centimeter also. But yeah, they used to be like less than 4 centimeter in most of the cases. The disappearance of the apparent mass as the effusion resolves definitely establish the diagnosis. So yeah, the disappearance of these mass as effusion resolve definitely establish the diagnosis. It is due to phantom tumor or vanishing tumor. So yeah, here we can see a multiple these like vanishing tumors. Here we can see in right horizontal fissure, and then in right major fissure in lower portion. And here in lateral projection we can see, again we can see in these all the diagrams. Now they are telling like how to differentiate between right middle lobe atelectasis and phantom tumor of the lower part of the major fissure. So they are telling at times it is difficult to differentiate encapsulated fluid in the lower half of the major fissure. So yeah, lower half of the major fissure from the atelectasis of the right middle lobe. So how to differentiate them? Then they are telling like the following are 3 points which helps make the decision or distinction. First is if the minor fissure is visible as a separate shadow, the diagnosis of encapsulated fluid is certain. Very, very important. If minor fissure is visible as a separate shadow, it means it is due to phantom tumor only. Very, very important. Second thing is encapsulated fluid does not usually obscure the right heart border. In contrast, middle lobe atelectasis almost invariably does. Means right middle lobe collapse always obliterate the right border of heart, but phantom tumor never does this. Third is like in lateral projection, loculated effusion usually have a convex border on one or both side. When the right middle lobe disease is there, the border of the shadow are either straight or slightly concave. So yeah, they are telling like the border are like convex in case of this um, uh, phantom tumor of lower part of major fissure, but in case of right middle atrial axis, like border will be either concave shape like this, or they will be straight like this, but it will never be like this. And this kind of border are visible only in case of phantom tumor of lower part of major fissure. So here we can see, like here we can easily differentiate like this thing is because of right middle lobe collapse or atrial axis. And so like this border is like convex or straight, sorry, concave shape or straight, we can see in this diagram. But here in this diagram we can easily differentiate like this is convex shape. So this convex shape is there, and like it is obliterating here the right middle right border of the heart, but here phantom tumor is not obliterating the right border of the heart. So yeah, these are very very important things which we should remember. Now they are talking about the lateral decubitus chest X-ray in the pleural effusion. So as little as 5 ml pleural fluid can be seen on properly exposed decubitus radiograph. So like lateral decubitus chest X-rays are very sensitive to detecting like very less amount of the pleural fluid also. So distance between the inner border of the chest wall and the outer border of lung is less than 10 centimeter, then we should not do diagnostic thoracocentesis. It is very difficult and it could be due to pleural thickening. So yeah, if it is so like they are telling, if distance between inner border of chest wall and the uh, outer border of the lung, so this distance is like less than 10 mm, then we should not try the diagnostic thoracocentesis. So they are talking about only lateral chest X-ray. Bilateral decubitus chest X-ray should be ordered. The film with the suspect side superior is informative because in this view the fluid gravitated toward the mediastinum. With the fluid shifted away from the chest wall and the lung, one can more readily assess the underlying lung for the infiltrator atelectasis. So like to differentiate from the infiltrator atelectasis, we should do like this lateral decubitus chest X-ray of like right and left both side. So here we can see like these are lateral decubitus chest X-ray, and these are like showing accumulation of fluid. In this diagram we can see that accumulation of fluid. In this another diagram we can see accumulation of fluid. They are talking about the four signs to identify lateral decubitus. Either it is right lateral decubitus or it is left lateral decubitus. So first, the dependent lung receive a greater percentage of the perfusion and more radiodense. So they are telling like whichever is the like dependent portion of lung, it will receive more vascularity and more perfusion. It will be more radiodense in chest X-rays. Second thing is like with the patient in the decubitus position, the abdominal pressure is greater on the dependent side. Therefore, the diaphragm on the dependent side is pushed higher than the contralateral diaphragm. So yeah, on dependent side, the diaphragm will be pushed higher than the contralateral diaphragm. Very, very important. After that, they are talking like third condition is like third sign is like the radiolucent padding on the examination table is often evident outside the thoracic cavity on the dependent side. So it will be on dependent side only, like radiolucent padding will be on the dependent side. Fourth is if air fluid level are present in the stomach or in the intestine, the air will be always on the superior side because air used to go away from the gravity. So yeah, CT in the pleural diseases. What is the role of CT scan in the pleural disease? If the angle of abnormality with the chest wall is acute, like this is the chest wall, and if angle is like this or like this, then the lesion probably has a parenchymal origin. Means like it has been growing like this. Whereas if angle is obtuse, then the lesion is probably due to malignant in position. Like if it is like this, then here we can see this is like obtuse angle, so it is due to the origin from the pleural surface, like mass is originating from the pleural surface. So this is like first thing we can rule out in CT. Then they are talking like free flowing pleural fluid produces a sickle shape opacity in the most dependent part of the thorax posteriorly. So we used to do CT in the lying position, and like fluid used to accumulate in the posterior part, and it used to produce sickle shape opacity. Loculated fluid collections are seen in lenticular opacity of the fixed position. So they used to be appear in fixed position, the loculated effusion. But like this free flowing pleural fluid in the most of the CT scans, they used to be there in the posterior thorax. Then they are telling like chest CT is particularly useful in distinguish empyema with air fluid level from the lung abscess, or as discussed subsequently, in patient with pleural effusion, CT can identify the pleural thickening, which suggests the patient is having exudative effusion. If patient is having like pleural thickening, then we should suggest like it is due to exudative pleural effusion, and we can differentiate from the CT like either it is due to like lung involvement or from the pleural involvement. Added bonus with CT is clear demonstration of the bone pathology. So like we can clearly see like bone pathology, or is there any presence of mats or tubercular of the bone. Then they are telling like patients with malignant pleural effusion had pleural nodularity and irregularity of the pleural thickness. So yeah, there will be irregular pleural thickness and there will be nodularity on the pleura. Then we should suspect it is due to malignant pleural effusion. Then they are telling ultrasonic examination are preferred to CT when primary question is whether pleural fluid is present or not. So to confirmation of pleural fluid, we should do USG rather than CT scan. CT examination of chest have also been used to evaluate the major and minor fissure. So to evaluate major and minor fissure, we should perform a CT. So yeah, there are several signs which used to be we used to do to differentiate from pleural effusion from ascites. Either like it is ascites or it is due to pleural effusion, then we should perform a CT scan. So yeah, there are like four signs which used to differentiate from uh, either it is pleural fluid or it is ascites. So first sign is displaced crust sign. So what is the displaced crust sign? Displaced crust sign is seen due to pleural effusion. So here, if pleural fluid used to get accumulated, then it used to push the diaphragm. If it used to push the diaphragm, then it used to produce displaced crust sign. Then second sign is diaphragm sign. Here we can see like this is the diaphragm sign, and it is due to the presence of ascitic fluid. So yeah, if here we can see like this is the diaphragm, which is like very easily visible, and outside inside the like diaphragm there is presence of this is like presence of ascitic fluid. The solid black line represents the diaphragm. The position of the fluid relative to the diaphragm identify where the fluid lies. Inside the diaphragm is ascites and outside the diaphragm is pleural fluid. They are telling if fluid is lying here, then it will be because of pleural effusion. It is lying here, then it is due to ascitic fluid only. So this is in this case it is due to ascitic fluid. Then they are talking about the diaphragm sign in USG. So how it used to be given? So here we can see this is the pleural effusion, and like inside the diaphragm this is the liver and this is the ascitic fluid. So yeah, diaphragm sign, because of diaphragm sign we can see like this is because of ascites, this is because liver. Inside the diaphragm it is the ascitic fluid which used to be visible. Here we can see this is the interface sign. Because of ascites we can differentiate easily like this is there is a interface between the fluid and the liver. So liver and ascitic fluid is having different consistency. Because of that we can easily see like there is an interface between both of them. And there is a bare area sign. What is bare area sign? Bare area sign is like ascitic fluid will never go. Ascitic fluid will never go in the bare area because of restriction of few presence of few like peritoneal involvement. It will not go in the bare area. It will be restricted by these ligaments. So yeah, because of the falciform ligament, bare area do not have any peritoneum and it does not having any ascitic fluid, and it used to get restricted here till here only. So yeah, this is because of ascitic fluid, and there is no fluid in this bare area. So these are four signs which used to by which we can differentiate between the pleural effusion and ascitic fluid.